Good morning, everyone. Thank you for joining us today. My name is Georgia. I'm the Project Support Officer for the Paediatric Integrated Cancer Service, and I will be acting as your moderator for the session today. I would like to begin the session by acknowledging the traditional owners of the land on which we are virtually meeting today, the Wurundjeri people, and pay my respect to elders past, present, and emerging. Today is the final webinar of a series designed for allied health, administrative and support staff as an introduction to paediatric oncology. In previous sessions, we covered paediatric cancer in Victoria, types of childhood cancers, types of treatment and side effects, and the psychosocial impact of childhood cancer on patients and families. If you missed any of these sessions, we will circulate links to the recordings in the post-session email. Today, we will be hearing from Lisa Barrow, clinical nurse educator at the Children's Cancer Centre at Royal Children's Hospital, who will be discussing clinical care. Before we get started, if you do have any questions throughout the session, we ask that you please submit them via the Q&A button at the bottom of your screen. As this is an open session, however, we do have staff attending from multiple health services, so we ask that you refrain from sharing any sensitive patient information within your questions. We will also be using Socrative later in the session today, and we will be testing your understanding of some of the content that we've covered throughout the presentation. You may log in now using the details on the screen. However, we will provide those later as well. So if you don't have time now, just hold on and you can log on later. Please note as well that we will be circulating the slides in the post-session email along with a recording of the session. So if you would prefer to just watch and not take notes, feel free to do so. Now, without further ado, I would like to welcome Lisa to take us through the session.
Hi, morning everyone. As Georgia mentioned, I'm Lisa Barrow. I am the clinical nurse educator at the Children's Hospital, and I run a number of the study days for PICS and for RCH and throughout the services. Today I'm going to talk about a couple of areas of clinical care, but feel free to ask any questions as we go along. I've just focused on probably 4 areas that you may come across, which is clinical trials, vascular access, cytotoxic safety, and some isolation precautions during the neutropenic phase. I'll just start sharing my screen and we'll go start. Okay. Hopefully that's okay. We've got, so the first, as I said, we're going to just look at a couple of areas of clinical care, and I'll see if I can answer any questions as we get to the end of it. George has already gone through looking at using Socrative. I've only got a couple of questions just at the end, just to sum it up, and we'll go through those. So as I said, we're going to look at the role of clinical trials in paediatric cancer and why these are important and why we actually use them. Just a bit about vascular access and the devices that we do use and some considerations that you may need when you are providing care to our patients. Now where was up to? So we're just going to look at some of the issues on cytotoxic safety and what you need to be aware of when you are seeing our patients. And also, as I said, the isolation precautions or neutropenic period, what things we need to consider during that period. Next slide, if that's okay. Thank you. So what is a clinical trial? You probably will hear us talk about clinical trials, protocols, oncology treatment plans, that sort of thing. These are actually a form of, as it says there, a form of human research designed to look at the effects of an intervention, such as a treatment or a diagnostic procedure, when we use them in the clinical setting. Main thing that probably as a nurse I'm involved in is actually the use of a drug or a treatment to actually treat the children and see what the outcomes are, looking for overall cure rates and also the side effects that we may see in these trials, or late-term effects that the children may actually be left with following a clinical trial or a treatment plan. There are other different types, and I'll talk about them as we go along. It's not just relying on the use of drugs in treating the cancer. There's lots of other things that we can actually do with clinical trials, such as psychosocial interventions, that sort of stuff as well. So I'll talk about a couple of those as we go along. Main thing to point out when you look at a clinical note on in the patient's history, you might see things mentioned such as ANZCHOG, which is Australian New Zealand Children's Oncology Group that we're affiliated with, or you might hear COG, which is Children's Oncology Group, which is the American-based group that we also have clinical trials open with. And COP is in a European-based group that we also use some of their clinical trials. So the idea is that it is an international collaboration, that we're actually working across really the whole world to try to get good outcomes for treating childhood cancer. As Chris and Jane probably discussed earlier in the piece, we only make up about 1% of the total incidence of cancers in the whole population. So we're a very small population, and a way to actually be able to follow what's happening with these children on treatment is actually to collaborate with our international colleagues and get good numbers enrolled into these clinical trials and be able to find out what the outcomes are from clinical trials, and can we actually get a great cure rate for these children and leave them with a good quality of life once they've finished treatment. So that's just a couple of their groups that we are affiliated with and that you will see on the treatment plans or the top of the chemo sheet, or in their notes that you'll actually see that we actually using a clinical trial with one of these groups. Next slide, thanks. So outcomes of a clinical trial may look at improving the overall survival. So even though we're stating things such as in leukemias, we're getting cure rates 85%, even a bit larger. We would still aim for getting the best cure rate we can, aiming for 100% or as high as we possibly can to cure childhood cancer. The other thing we do look at as well is when we're actually using clinical trials, can we actually reduce some of the side effects that we do see with the use of these drugs, or otherwise the late-term effects we see from treatment for children with childhood cancer. And that's some protocols such as there's a lymphoma protocol that we actually know that we're getting a good cure rate up to about 95, even 98% cure rate. But we do know that some of the side effects from that treatment is potential for infertility or a potential for a rare incidence of a secondary cancer later in life for that child. So what we're aiming for with the cure in clinical trials such as that one is we still want to get that great cure rate, but we're trying to actually see if we can actually maybe minimize those later toxicities, maybe decrease the dose of one of the agents called cyclophosphamide that we generally use in that treatment protocol. So by decreasing that dose, can we still get a great cure rate, but also decrease the chance of that child becoming infertile or otherwise developing a secondary cancer later on. So that could be other things that we do try to do when we're looking at clinical trials or trying to improve them. And the other thing is improvement in quality of life. So we do know late effects is another talk to look at, but we do know that children can be left with impacts on their life. We might cure them, but there are some things that they may be left with that they need to deal with throughout the rest of their life. And I've talked about, say, secondary cancer and that sort of stuff, but it might be things such as learning difficulties, lots of other stuff, problems with their heart, that sort of thing. So we're aiming also to keep that cure rate up, but maybe we can minimise those side effects. I've just quickly popped on a couple of different examples. So you might see these mentioned. So AAL0932 is one of the leukemia protocols. I've mentioned one down the bottom called LOXO trial. It's just a phase 1 or 2, and I'll explain what the phases are in one of the slides coming up. And also PRISM, which is an example, probably more of a biological study, or what we're looking at is trying to understand the disease and see if we can actually target those cancer cells with different treatments. So understand what's molecularly going on with that in that cancer cell when we have a look at it, and see if we can actually find an individualized treatment for that patient that we might be able to target that problem in the cell and be able to kill it off that way. So these are a couple of different clinical trials that we do have open, but there's quite a number of them that we do have. Another thing to mention is also clinical trials may actually be able to give us access to new drugs that are not readily available. So this might be in things such as phase 1 or phase 2 studies, and that LOXO is an example of that. That there was a, I think in the past month or so, there was actually an article or a session on the project that actually discussed a patient with a brain tumour, and they actually have that. After using a trial similar to this, they've actually found the brain tumour has actually shrinked, and LOXO is actually now a drug that has just been approved by the TGA, and it's going to be hopefully available within the next year on the PBS, so they'll be able to access it much more readily for patients with, say, brain tumours, central nervous tumours that are advanced. So that's really exciting. This is some of the things that we actually are now learning or looking at, is actually new treatments, new drugs that we can actually prove that they can clinically work, and then can they actually be made an ongoing part of treatment. Next slide, thank you. So one of the other types of clinical trials, so tissue banking, or it's often an observational study, or otherwise called a non-therapeutic study. I don't necessarily like the term non-therapeutic because it's all something to do with their therapy, but tissue banking is something where we actually take samples of the cells or the tumour when they are enrolled on a trial, and we actually either store that for future reference or to be able to look at those tissues and understand the disease a little bit more in depth. And as I mentioned, PRISM is probably a similar sort of thing, that we're actually taking those cancer cells and looking at them and trying to actually understand what's going on, what's happened in that cancer cell, and identify maybe there's a different target that we might be able to use. Rather than chemotherapy, we might be able to use some other drugs or to actually specifically target what's happened in that patient's cancer cell as an ongoing treatment. Again, most of the things with clinical trials, that patients do need to consent to be enrolled on them, and most of the patients are happy to actually provide samples of their cells or their tissues for us to actually have a look at. Other areas are also quality of life studies or supportive care interventions. And what we're doing for those is looking at trying to improve comfort or the quality of life. So some of the things that we have done as clinical trials or projects is things such as looking at central line care. We did a number of years ago a thing called an ethanol lock trial, which is actually seeing if using a different type of flush in the lines could be managed by patients and families at home. So they would actually provide all the central line care, and that actually would then decrease the incidence that they need to come into hospital or have care provided by the hospital team. Another one is also febrile neutropenia in the home environment. There's a low risk program that has been ongoing now and is actually going Australia-wide, and has also actually now been in COVID, it's actually been taken up over, I think it's in England, over in Europe. And this has actually been able to offer the kids treatment at home for their febrile neutropenic episode when they're in a low risk category. So they don't actually need to, in this instance, be sitting in a hospital bed for antibiotics for an episode of an infection. They can actually be having their care provided at home, which is really exciting as well, that it's actually now been taken up overseas as well. Again, patient consent is also required in this instance. These are just some of the other examples. So it's not just drug treatments that we look at and curing the disease, but what actually we can do to, in provision of care for the children as well. Next one, thank you. Now, this is probably the main one that you may be aware of. As a nurse, this is probably more what we focus on. These are interventional studies or therapeutic studies where this is actually where we're looking at the drug treatment. And it might not just be drugs, the chemotherapy. It might also be the use of the radiotherapy and surgery at different time points in their treatment. So these clinical trials, you may say things such as AALL0932, and that was one that I popped up a little bit earlier as well. That's a COG protocol, and this is a protocol that we use for our leukemia patients. It's actually called a phase 3 treatment. So what we did try with this one was actually just trying to improve care a little bit, that maybe we could actually do some of their care more as an outpatient rather than sitting in a hospital bed. And there's a couple of other things that we did look at this. So at the moment, this is now what we call a standard of care. It's not, I believe it's not actually an open protocol, but we're using it now just as a standard of care for leukemia, certain types of leukemia patients. So we will always ask them to enrol in a clinical trial. If the parents decide that they don't want to provide their consent to be enrolled in a clinical trial, it doesn't necessarily mean that they're going to miss out. It won't mean they're going to miss out on treatment. What we will do, we'll actually just provide them with the best published standard of care treatment that we do have available for them. It's probably more something that we need to look at in phase 1 or phase 2 trials, which I'll talk about in a minute, where we actually need them consenting to be on the clinical trial to be able to access the drug for them. But generally, it's saying that they don't want to consent to be enrolled in a clinical trial doesn't mean they're going to miss out on any of care. We'll provide them the best possible standard of care that we have available for them. As I mentioned earlier, we're affiliated with worldwide with different groups, and that is to actually get a good cohort of patient numbers enrolled in the trials so that we can actually follow what is happening, proving that the drugs are effective, that we've actually got even a better regime available. The problem is that some of the trials are only open at a number of hospitals. There's lots of processes of accreditation that we need to follow, ethical approval to actually be able to open a clinical trial at a hospital. And unfortunately, sometimes it may mean that the only place that the child can actually have their treatment for their disease is actually at either RCH or Monash, that we might not be able to offer treatment at a regional hospital. They'll still have to come to hospital for their chemotherapy regimes, but we might be able to at least be able to provide some of the supportive care, such as line flushes at regional centres. Other thing is as well, some kids, unfortunately, because of what is set up at each hospital, some of the children at Monash will actually need to come over to RCH for things such as stem cell transplants or rescues. And some of the clinical trials, such as CAR T cell therapy at the moment, is only open at the RCH. And that's just because also we actually need to have labs associated with that, and a really good system with the labs and access to the cells that we need to use. And so unfortunately, during some children from Monash may need to actually travel into RCH to have certain phases of their therapy here, and then they could go back to Monash for follow-up care. Next slide, please. So just quickly talking about phase 1 and phase 2, these are two areas. So the LOXO one that I talked about a little bit earlier, these are actually different types of, I suppose, drug trials, where we're actually looking at how the actual drug works in the cancer that we're looking at. So it might be, say, a high-grade glioma. Will this certain drug actually treat that disease? And also, what is the most effective dose that we can give the children without really bad side effects, I suppose, is the way of looking at it. So we're trying to learn about how the body will respond to the drugs that we give, and actually that we're not going to give the children really nasty side effects associated with it. So often these clinical trials, phase 1 and 2, are ones that we use for relapse or refractory diseases. So the disease hasn't necessarily responded to treatment as we would like. So we may look for something else, which would be maybe enrolling them on a phase 1 or phase 2 trial. What we do often need to do in this instance to get access to the drug is that we do need enrolment on the clinical trial. So we need the consent from the family to be involved in the clinical trial and have access to that drug. But this is how, as I mentioned earlier, we learn about the treatment, and we can actually then be able to prove that the cancer does respond to it. And as I mentioned, Loxo, now we actually have TGA approval, and it will be available on the PBS within the next year. The other one I put up there is a Bianca, easy way to call it is just the Bianca study. This is actually using now CAR T-cell therapy that we've now started a trial for using CAR T-cell therapy that was mentioned in one of the other presentations. And this is a way of getting the immune system to fight the disease. So in the Bianca's trial, we're actually using now CAR T-cell therapy to treat lymphomas, B-cell lymphomas. So we have used it in leukemia, and now we're looking at it in trying to treat this type of lymphoma. So this is another exciting area. This is where we're learning about immunotherapy or using the immune system to actually be able to treat the disease. And this is another open trial that we have started as well at RCH. Next slide. It's okay. Now, phase 3 is the most common type in the paediatric cancer that we do use. So the earlier one that I mentioned, the leukemia one, 0932, that you might see on the clinical notes. That's an example of a phase 3 trial. This is where we're just trying to learn if a treatment is effective in curing a cancer. We actually probably know that, but is there a better way that we can do it? So as I mentioned, can we actually tweak it a little bit and get better cure rates? Can we tweak it a little bit and mean that they actually get treatment in day cancer rather than sitting in a hospital bed? Can we get a longer control of the disease? Can we effectively cure it, or can we control it for a long period of time? And also decrease the side effects. Can we do a bit better and decrease the side effects in this instance? So this is the most common type of clinical trial you'll hear about, which is a phase 3 that we use in treatment for as a standard for different types of diseases. So that's just a brief overview of it, of what, when you hear different terminology and why we use different things and why we need consent. Have many different types of clinical trials because we're trying to individualise treatment and provide the best cure rate for the patient with that type of cancer. Some of the implications for allied health in this instance may be that their health assessments may be an integral part of the clinical trial. So we might actually ask for, say, neuropsych assessments as part of that clinical trial as follow-up to see what is happening from their child's treatment. Also, allied health are a really integral part of overall in our provision of supportive care or noticing side effects. So things such as even, say, physio or there's an agent we use called vincristine, which is quite common in a lot of our trials in our treatment protocols. Vincristine causes things such as peripheral neuropathy, tingling in the extremities. They can't actually feel for a certain period. A touch sensation is gone. They might have what we call foot drops that they need physiotherapy intervention. So a lot of the time, allied health, just in your general day-to-day, sorry, it's gone out of my head, day-to-day management of our patients, you might actually notice some of these side effects. And these side effects are things that we actually need to report back in a clinical trial. So in provision of your supportive care or in your day-to-day dealings with their patients, you may actually be one of the first people who actually notifies us of a side effect or something that we need to actually report in that clinical trial. Other thing to mention with the clinical trials or the patient's treatment, often the kids do have to have lots of different follow-up tests, and they may need to come back in for hearing tests or echoes, that sort of thing as well. So what we try to do and ask Allied Health where we can in planning is actually try to plan their treatments or their follow-up, their treatment or their appointments with their follow-up visits as well, so that patients don't have to come in and out of hospital at different times or different days for appointments with members of the team. It may not always be possible, but we do try to coordinate it so that, as an instance, they don't have to come in for a hearing test at 9 o'clock in the morning and then have to wait around in the hospital until they can start their therapy or their chemotherapy that night at 8 o'clock. So what we try to do as best we can is coordinate their care so that they only have to come in and get most of their appointments done on the same day. Okay, next slide. Okay, so the next one I'm going to quickly look at is vascular access and talk about more so the two main types that we do use. So there are two types of vascular access you may hear us talk about. So there's peripheral, which is a cannula. It's the first picture on this slide. It's cannula inserted into the arm, hand, leg. Generally, it's probably the arm or the hand. It's just what's left in there is a small plastic straw, and that's what we can infuse their therapy into the patient through an IV cannula. Some of the problems with IV cannulas, for one thing, when you look at the position, where often we'll put them, unfortunately, in a limb that a patient wants to use. So a hand or an arm, and the patient actually wants to be drawing or eating, all that sort of stuff, and we've immobilized that. So that's some of the problems with it. It doesn't take, peripheral cannulas don't take a lot of fluid, and they can also be irritated by some of the medication that we put in. So peripheral cannulas are probably a very short-term vascular device we use. And that's probably when a patient is diagnosed. It's the main time you'll see a peripheral cannula used with our patients. What we generally try to do once a patient is diagnosed is actually put in a central line, so a CVAD, a central venous access device, as soon as we possibly can. So this does involve insertion by the surgeon on the theatre list, but we do try to get it in as quickly as we possibly can. There are a couple of different types. So there's external line, which is on the second picture, and that's an example of a Hickman, which is a tunneled device. It's tunneled under the skin and enters the vein up in the neck. So Hickman's probably a common one we use, or there's also a thing called a PIC, which is a peripherally inserted central catheter, which is probably more commonly put into the arm. It's a longer tube than a peripheral and a bit more similar to a Hickman, but it's put into a vein in the arm, and then the longer tube follows up the vein. The other one we use is a portacath, which is implanted under the skin, and I'll show you a picture as we go along with these. So more commonly, the two types of devices you'll see in our kids are either a Hickman or a portacath. The beauty of a centralized CVAD is actually it can stay in for months to years. It can take lots of fluid. It actually gives us multiple lines that we can run medications. Medications that don't necessarily mix together, we can run them at the same time down those different lines. And as I said, they can stay in for quite a number of years. Next slide. So this is an example of a Hickman line, just to show you it is often inserted in the chest wall, and the line actually then tunnels under the skin. and enters a vein in the neck, generally into the jugular or subclavian vein. And in this picture, you can actually see the tip of it actually is located in SVC or just near the heart. So it actually does have two, I suppose, when you look at a patient, they have two insertion, it looks like two insertion points, but one on the chest wall is where the catheter goes in, tunnels under the skin, and then in the neck, you'll find that they actually have looks like another cut there, and that's where the surgeons used being able to put the line directly into the vein. It is put in surgically. It's often sutures in. It will come back with the dressing over the insertion site in the chest, and this is what we need to change weekly as an ongoing care. We can get single, double or triple lumens, which actually means we could actually have 3 lines that we could use hanging out of their chest. But generally the most common type you do see in our patients is a double lumen Hickman. So it looks like there's 2 lines on the externally on the patient's chest. Stat locks and biopatches are different devices. So stat lock is a stabilization device, which we actually then, I suppose it's a bit like a tape that we actually use to actually stabilize it onto the chest wall, a bit more of a backup if the line gets a pull, and a biopatch is another type of dressing that we use around the insertion site. So these are one type that we do use called a Hickman line. The next slide, please. Port is the other type that we do use. So port is a similar type of surgical procedure. Again, it's put under the skin, but it looks like a little button hidden under the skin. The line then tunnels up under the skin to insert into a vein generally around the neck area. And the tip again is located at SVC or just near the heart, the end of the line. With the port, we do, it is hidden under the skin and looks just like a little bump if it's not accessed. We do, however, need to access these, need a specific needle to put into the port. So the child may need some cream on before they come in to numb the area, and then we'll access it by putting a needle into the portacath and have a line hanging off that to the IV. We can have single or double lumens. We do see both. Single is probably what we see in a standard ALL patient, and we do know that we can get by their treatment by just using a single portacath. But we do have double lumens. So some of our osteosarcoma and Ewing's patients, so the bone cancers, have a double lumen portacath put under their implanted under their skin, and that just means is actually that we can actually give again medications that don't necessarily mix together. It's actually 2 lines hidden away under the skin. They're sort of combined together, but it actually gives us 2 lines that we can use. And these again can stay in for a number of years, and we can have over 1,000 accesses of the port, so that we can use. So these are the 2 different types that we do use. Some of the advantages are that that we can use chemotherapy that doesn't mix. With a double lumen access, we can actually, if the patient gets quite sick, we can feed them. So we can use TPN, we can use irritant drugs using a central line, either a port or a Hickman, that wouldn't be tolerated by the peripheral line. And also, that they can stay in there, they don't get irritated, they don't fall out like a peripheral line does. So they're much easier to manage from a patient perspective. Next one. So as I mentioned, some of the pros was that we can give the chemotherapy, medications don't mix. We can use them for blood tests, so we don't always have to cannulate them or put in peripheral cannula or do a finger prick. We can use them for fluids, feeding them by total parenteral nutrition. There's many reasons that we can use it. There are other things that we can use it for is those very irritant drugs. So a lot of some of our chemotherapy can actually harm the veins or harm the tissue. And so we need to actually have a central line put in rather than a peripheral cannula that we know that it's not going to harm those areas. Some of the only way to remove some of these devices once they've finished treatment is either a Hickman can be pulled out by an experienced nurse on the ward, or otherwise a surgeon. A portacath does need surgical removal, so they would need to go on list and have it surgically removed under a general anaesthetic. So generally, we're probably about 6 months post-treatment, we'll actually aim to remove their CVAD. They might stay in a little bit longer, but generally we try to get them out as quick as we can once they finish treatment. Unfortunately, though, there are times that we do have incidents that we have complications with them, whether they block, or it's probably more common that unfortunately some of them will get infected. And although we try to treat them with antibiotics and try to save them, it may be that that central line has to come out, and we would need to put a new one in at a later stage. Next slide. So some of the indications for allied help is these devices, although we say they can stay in for a period of time, they do need either regular dressing changes or regular flushes. And so they do need some procedural pain management or support just for the patients. So we might use comfort first, involved with the nurses, and actually try to support the patients while they are having these procedures. So even removing a dressing, if you can imagine on the chest, can be quite confronting or annoying for a patient, especially a young child. Or otherwise, even just the thought of a needle going into a port, even though we use numbing cream, it might be that the patient needs some support to actually be able to manage this. Hickman lines do need to be changed every week, and they need to be flushed every week with heparin. Portacaths have probably more of an advantage that if we don't have to cannulate them, they can actually last for about 4 to 6 weeks before we need to actually cannulate them and flush them. So if the patient isn't needing therapy during that time, they may actually just be able to manage that. They don't need to actually have a hospital visit for management of their CVAD. Other things just to point out, allied health staff, watch the IV lines. Even as nurses, we can trip over them. They can get caught on equipment, on clothing, on beds when you put down the bedsides, bedside tables. And we have had them, unfortunately, being pulled out, even the Hickmans. So I do remember poor father who was nearly put in Hickman line, and he did get his child up to, it was only put in about two days ago, and he did get his child up to have a bath, and sure enough it got caught on the bed and completely just fell out. It hadn't really secured itself, hadn't had time to granulate and secure itself in the area, and unfortunately it did fall out. So always just watch. You never know that we can actually always potentially trip or pull those lines or get them caught on something. We always ensure that they're secured, so whether it's a bit of a stat lock, it might be a safety pin as well, a bit of tape and safety pin that we hook onto their clothing. But we always try wherever we can to ensure that they're secured as best we can with those devices. So even if they get a pull, they're going to pull on the clothing rather than actually pull on the line. I've just put a point in there, never use scissors near an external line. Unfortunately, there has been instances that a child has actually cut through their line. So if you're doing art therapy or that sort of thing, and doing a bit of play, just be very cautious when you've got scissors around the area. You will find that we talk about things such as aseptic technique, vascular access bundles. So there's a lot of different amount of training that we need to, as nursing staff, we need to have to actually make sure that we handle these lines properly, and we don't actually inadvertently introduce an infection. So one of the points of managing these lines is that we need to have closed systems. So you will find that we will try to ensure that all the central lines and lines do remain connected at all times. It might be that they just have ongoing therapy that we need to have connected all the time, but also we do try to keep them connected rather than disconnect, reconnect as we go along in between antibiotics, because each time we do that, there is a potential that we could introduce an infection. So you will find that we generally will actually always keep the kids hooked up to these. If they're a long-term patient, we may be able to disconnect them so they can have a little bit of time off the ward. But most of the time, the kids, if they are in, we will always keep them connected up to their lines. And we do discourage the children from leaving the ward without a nursing escort if the lines are connected to them, because we do need to make sure those pumps and IVs are working effectively. Another thing to point out, if the pump is beeping, some people do press, press silence on there. We do need to be notified that if the pump's beeping, the nurse will need to come and have a look at it. We can't just put it on hold for a period of time because that actually may cause an occlusion in that line. So always, if there's a problem, just let us know. They might be in the play area, and just give us a buzz and let us know that it's beeping and we need to come and fix it. If you come across that a line does unfortunately disconnect, so some of the connections might fall apart, or unfortunately the line itself does break, if you can there are clamps on lines, if you can try to press the clamp and close it above the break, or otherwise you can even pinch off the line. So closest to the patient, just pinch off the line and give us a buzz that we come and try to fix up that problem, either reconnect some new lines, or otherwise we may actually have to do a repair on the line itself. And there may be some physical activity restrictions. So generally kids with Hickman's, unfortunately because the lines are hanging out of their chest, they unfortunately can't do swimming. They need to be very cautious when they're having a shower or bath. They can't submerge the lines into the bath. But kids with ports later down the track in following their therapy, they can actually go swimming because if it's not cannulated, it's just a little bump on the skin. So they may actually be able to do swimming, but we do know, unfortunately, with the Hickman's that they need to stay out of water. And we just need to be cautious with these lines, and even with the port, that probably avoiding avoiding contact sports is probably something we do need to look at as well. Okay, next slide. It's time. So if you find that you come across any problems with the lines, please let us know, whether it's beeping, whether the child may actually be caught up in their lines, may have twisted them quite a bit, it might get caught up on the bedside. Any problems at all that you notice with the lines, even if you actually see, we do need to keep an eye on their sites quite regularly to make sure they're not infected, that they're infusing properly, that they're not leaking. So anything that you notice in that instance, please let us know, and we'll have a look and see what we need to do about it. Okay, next slide. Quickly to talk about cytotoxic safety. So you might hear the words chemotherapy or cytotoxic. So chemotherapy is generally the drug therapy that we do use. Some of these agents that we do use are what we call cytotoxic. So cytotoxic means that they can kill cells. The thing with cytotoxic therapy is that it will kill the cancer cells, but it also kill any healthy cell that's going through cell division or actually producing more of themselves. So any cell that is dividing and producing more cells will be affected by the chemotherapy. So we do use them to kill cancer cells, but unfortunately it will harm healthy cells as well. And that's why we get some of the side effects, such as the hair falling out, the bone marrow suppression, the gut falling apart, getting myositis, that sort of thing, because of some of the side effects that we're killing off those healthy cells. The cytotoxic, how to identify if an agent is cytotoxic or a child is having cytotoxic therapy, you will see either on their medication, they have the label cytotoxic. Otherwise, that little symbol there where with a cell dividing, it's called they're going through the telophase phase of cell division. So that little symbol there, if you see that, the name cytotoxic, or otherwise the colour purple is used in Australia and New Zealand to identify a cytotoxic agent. Other ways that you can see that is that these labels will be on the IV lines, it'll be on the drugs that we're using, or at RCH we use a a door sign that is on the door, just to notify us that a patient is actually having cytotoxic therapy, and we might need to put on some other equipment such as PPE, such as a gown, mask, gloves, eyewear, when we're dealing with either these medications or dealing with body fluids. So that's just what you will see with cytotoxic. For allied health professionals, if we go to the next slide, some things you may need to consider. That any of the body fluids from a patient who has had chemotherapy or cytotoxic agents may be contaminated with that medication. So if you, for some reason, do need to deal with body fluids, whether the patient needs to go to the toilet or unfortunately they are feeling sick and they do vomit, we encourage you just to wear gloves if you need to touch those body fluids. For a patient, if they are with you and they need to go to the toilet, we often ask them to sit down, even boys if they can, just to avoid splashing. And when they've been to the toilet, we will ask them to close the toilet lid and use a full flush in flushing away the feces or the urine. If they vomit, just make sure, if you can, put on some gloves, double bag it if you can, and alert the nurse for disposal. So if you have access, please grab some gloves and then grab the bag and let the nurse know to come and dispose of it for you. If you find that they may vomit or there's a wee spill or something on the floor, or even if you're not sure of actually what it is, just isolate the area, just pop something in front of it and give us a buzz and we'll come and actually deal with it, because we may need to get a spill kit out and clean it up with a certain way. So just let us know if any of those sorts of things occur and we'll come along. One thing to mention after removing gloves, just make sure you wash your hands really well with soap and water is the main thing that we ask. Okay, next slide. And just quickly, Chris mentioned last week, hey, I just would quickly go through some neutropenic precautions or isolation precautions. So I'll quickly touch on those and some of the considerations for yourselves as allied health staff. Just recapping quickly the neutrophil and why we focus on neutrophils so much, or you hear us talk about neutropenia. It's one of the main white blood cells that fights an infection. It's really good at gobbling up or destroying a bacterial infections, and it's one of the first cells that will actually deal with an infection. So anything that's a bacterial infection, neutrophils are responsible for dealing with those. Neutropenia, so neutropenia generally happens about 7 to 10 days post chemotherapy. It depends on what sort of chemotherapy they have had, but anywhere from 7 to 10 up to 14 days, we would actually consider that if a child presents with fever, they are potentially neutropenic, that they've had a drop in those types of white cells and types of white blood cells following the chemotherapy. So that's just a quick recap of what neutropenia is. We'll go on to the next slide. So implications for allied health staff, and this is generally across the board as well. And as we know with COVID and everything else, we're probably getting really good with our hygiene and our PPE and all that sort of stuff at the moment. But we do know that we always use strict good hand hygiene, hand washing, and attention to hygiene. So things such as rubbing our nose, coughing into our hand, that sort of stuff. We should avoid. So as I said, we're probably well versed with COVID and we do have masks now, but coughing into your shoulder, that sort of stuff, not rubbing your nose and things, not playing with your mask. If you can, we probably all inadvertently do this sort of stuff without even realising it, but pay particular attention if we do actually start playing with your mask, that we probably then need to go and wash our hands again. Again, for allied health, any equipment that goes into the room, any equipment that you're sharing with the patient, we probably should wipe them down. wipe it down with an alcohol swab or a tuffy. And there are visitor and staff restrictions that you probably have heard of as well. So most visitors are allowed for the patients, but if they're unwell, we discourage them from visiting. A different system at the moment with COVID, but generally, even if the patient was at home, in the general world without COVID, we would actually say most visitors can actually attend. But if they're unwell, any signs of fever, runny nose, cough, diarrhea, recent exposure to infection, those visitors should be discouraged from actually attending, whether it's a hospital or at home. And that goes to say the same for staff. And as we're told now, any of those presentations, we should not be attending work in the present environment. Okay, next slide. Other things that we need to be cautious of, particularly when you have appointments, we would avoid exposure to any other infectious contacts, and that's also with nursing them in the hospital. So we wouldn't put any of our patients probably in a shared room with a patient that has diarrhea or a cough or that sort of stuff as well. So we would avoid any potential exposure to any other infectious contacts. And large public areas for high-risk patients or any of our patients as well. So often when they come into emergency or to day cancer, we don't have unwell patients near them. In emergency, they have their own waiting area that they are away from the general population. So we would avoid any large public areas for high-risk patients. So even outside of hospital, as I said, taking away COVID, they could probably actually go out and that sort of stuff, but we wouldn't actually say that they hang around large public, shopping areas, that sort of thing, theatres and things. But it depends where they are in their treatment, and that's something that can be guided by their treating team. So there are times following treatment that they could be doing those things, and they can be going to school as well. It just depends where they're up to with their therapy. There are some more specific restrictions for allogenic transplants. So there's those transplants that we actually have in our transplant suite here, where we've actually given them someone else's stem cells. So we've actually wiped out their diseased bone marrow and given them someone else's stem cells from a bone marrow source or peripheral stem cell collection. These patients, it's not just neutropenia that they have. We do actually get their neutrophil counts up following a transplant, probably within 3 to 4 weeks. So the neutrophils will actually be fine. It's actually their whole immune system. We've given them someone else's stem cells or baby blood cells. And those baby cells then need to learn all about treating infections. So it may actually take those patients actually up to about day 100 post a transplant or even a bit longer for their immune system to actually reconstitute itself and learn a little bit, learn again how to treat viruses, any sorts of fungal infections, things like that. So their immune system needs to relearn and have exposure or learn about viruses and things and how to deal with them again. So for those patients, although they may not be neutropenic, they still have an immune system that doesn't know how to function properly. So those patients we actually treat, we'll have them in a HEPA-filtered isolation room in our bone marrow transplant. In the transplant setting, we only have 4 nominated visitors. So it'll be generally parents and maybe 2 grandparents, and they're the only ones who are allowed to enter that area. And unfortunately, siblings of school age generally don't attend when they're in the transplant area. It's mainly because they haven't had exposure to lots of different viruses, infections, that sort of stuff. So the nominated visitors are probably more so going to be just the parents and maybe some grandparents. In day cancer, we have a separate waiting area. So those patients actually need to sit away from the general crowd around in day cancer, and they'll have a separate area that they sit. And we may find these restrictions will continue up to at least day plus 100, even a bit longer, until we know from the treating team that their immune system is now functioning okay, and that we know that they don't need to follow these restrictions. And I think Chris mentioned at one stage, because of all these restrictions, parents with cancer have mentioned mentioned that they are living in a way in a COVID world. What we've had to do now in the past year is actually what some of the parents feel that that's what they need to do with their child with cancer. They need to manage these restrictions as an ongoing basis. And probably now us as the general population has now had exposure in a way to the feeling of how we need to a child with cancer and a family of cancer may need to restrict themselves a little bit. Okay, next slide. I think that might be about it. So we're just going to do a quick quiz and then I'll open to questions.
I'll just give everyone a moment to log on. So if you just go to www.socrative.com and enter the room name Williams 5291. All right, we'll just get into the quiz.
Okay. Okay, some might have a look at this. So this is just asking about what the most common type of clinical trial was, which would be, if we have a look. Yep, so generally it's a phase 3, which is our standard treatment regime, I suppose, for our patients. But I have to admit, you will find that we are using a lot more of phase 2. So these newer drugs, phase 1 and phase 2, these newer drugs, we are actually using a lot more of these clinical trials in relapsed or refractory tumours to see if we can actually treat the disease and looking at the side effects that occur with them. So there's a lot of phase 1 and particularly phase 2 trials that we are actually seeing in our population as well at the moment. Next one. Two most common types of vascular access devices are okay, so yep, might have a look. Yep, so Hickman and portacath. So Hickman and portacath, so portacath's the one that is like a little button under the skin that we access with a needle, and Hickman's the lines hanging out of, generally 2 lines hanging out of the chest. A is potentially correct. We do use also PICs at times, but they're probably a shorter term device. They may stay in for a number of weeks to a month, but then we do need to remove them. So more commonly, it's Hickman's and portacaths that we use because they can stay in for a number of years. Single most effective way to prevent infections is, and hopefully with all our hygiene that we do have to do at the moment, yep, washing your hands. And we do all have to do our hand hygiene. So I'm not sure if all allied health do. I believe they would. I know we do at RCH. Washing your hands is the most effective way to prevent infections. Next slide. Cytotoxic precautions must be followed for how many days following chemotherapy? Yep, so 7 days. So some of the drugs actually may be excreted within a couple of days and may not be in the body fluids after a couple of days, but it's really hard to know when we use different types of chemotherapy across the board. So it's just generally a blanket rule that we go for 7 days following chemotherapy. Oh, and the aim of the clinical trial used in treating paediatric cancer may be to Yep, all of the above. So we're aiming for the best possible cure rate that we can get, but we're also looking at now late-term effects and quality of life, and decreasing side effects as well from the therapy. So we want the maximum cure rate, but we want to also decrease those toxic side effects that we unfortunately expose the patients to. And I think that's probably it. Thank you.
We have gone just over time, but we did have one question come through early in the session. You might have covered this. However, the question was, what are the impacts of lines for showering? And can the insertion area get wet first? Can we waterproof the area? So just whether you wanted to.
Yeah. So they can shower, so they will have a waterproof dressing on their lines. Unfortunately, sometimes they do peel back or they do leak, but generally what we say is not to submerge them in water. So they can shower, they can bath, but that dressing area should not go in the water. If it does leak or it does peel back, we generally discourage from actually reinforcing it, so we don't put another dressing over it, because we potentially have exposed the area and may have introduced an infection. So if we do have leakage and they get wet, the dressing's peeled, we generally will have to do another dressing change just to prevent infections.
Great, so that seems to be it for the questions. As always, if there's anything else that you think of or you have any questions now or down the track, feel free to contact Lisa or any of the presenters from these sessions, or alternatively, you can email pics.admin@rch.org.au and we will get your inquiry through to the correct person. We will be sending out the slides and this recording in a couple of days, and we will shortly send out an email requesting feedback on all of the sessions. So if you do have time, we would really appreciate any feedback that you can give. Thank you to everyone who stuck around for those extra 5 minutes, and thank you, Lisa. That was great.
Oh no, thank you. Thank you, everyone.
Bye.
All right, thank you.